I think the topic is rapid diagnostics in infections. Whatever I'm going to present may not be in particular with relevance to our oncology patients, because the data with the use of rapid diagnostic in oncology patients is actually emerging. So it is a technology tool that is available in the last decade. So there is not much data in this select group of population. What is very important is microbiology results are the key to managing patients with infections. Many a times we make a diagnosis, but it is always nice when we have a proof for the diagnosis that we have. Picking up the microbiology etiology is very, very important. So starting from doing the right test at the right time and your collaboration with your microbiology lab or histopathology, all those things is very, very important. And this information that we get from the lab in terms of overall data, the antibiogram, trying to predict what would be your number one, number two, number three organisms, what is the susceptibility, so that you have an empiric antibiotic choice based upon your local prevalence for urinary tract infections, for your bloodstream infections. That is very, very important. So if your hospital is not providing with you with data, I think the department has to make up an effort to talk to the microbiology lab, try speaking to them, and then get that information, tease out that information with respect to oncology practice, and then have your top three pathogens for diagnosis pneumonia, for diagnosis urinary tract infection, diagnosis bloodstream infections, diagnosis skin and soft tissue infections. Only that would help in getting the antibiotics right. So when you get that part of it right, then your choice with respect to antibiotics is going to be always right. It is always a combination of your clinical diagnosis backed by your microbiology, at times radiology and histopathology. And with respect to the newer molecular tests, I think it goes without saying when you do blood culture, it is always good volume blood cultures, 40 ml. I think that is a basic prerequisite for anyone with neutropenic fever or fever in oncology patients. We are looking at around 40 ml of blood, and that is there always. In addition to that, what are those newer molecular tests that we have? It could start with the single primer test like the H1N1 PCR, COVID PCRs. These are all something that target only one pathogen, that's it. And then you have the multiplex PCRs where you get an array of pathogens complexed into a single test. The H1N1 PCR is one probe for one organism. You may have that single test where it can pick up multiple pathogens. That is the multiplex PCRs. So the single PCRs and multiplex PCRs are in vogue. For example, the gene expert for tuberculosis is a single PCR. You can even pick up the rifampin resistance genes there. The future would be with respect to enrichment metagenomics or unbiased metagenomics. That is nothing but picking up all the pathogens. That is where the future is. But as the future goes, whatever we have, the detection range will be much, much higher. But what is the utility of that, we do not know. So if we are going to use a single probe PCR, the utility for that is much, much, much more. Because you are very sure regarding what was your diagnosis, what you thought, and then you got a test. So that distinction is something that we need to be very familiar with. This single primer PCRs, all of us are familiar. Thanks to CBNAT, the TrueNAT, whatever we have with TB, we know that it has made a big impact when compared to your AFB smear, something like that. Multiplex PCRs are in vogue in the last decade in the private sector. I'm not sure AIMS has, all the AIMS network have multiplex PCRs in them. I'm not sure whether in the government setup here in Tamil Nadu do we have that or not. So that is when we call this syndromic diagnostic approach, where you have a diagnosis of pneumonia. So that it could be because of multiple pathogens. It could be because of a virus, bacteria, something like that. But you try doing a single test that would pick up a variety of etiological agents that would be causing that diagnosis. So when you do a single test picking up that is what you call as a syndromic diagnostic approach. I'll just run through one case. This is a 32 years female with a community acquired pneumonia. So the bilateral basal infiltrates, and this was in the middle of a COVID wave, COVID second wave, where all the pneumonias that we were seeing were all COVID. This patient had a normal white cell count. The radiologist thought that the imaging, the CT chest was done. They gave a scoring also. The scoring was 8/25 COVID. So this looked like COVID. And this lady was housed in the middle of the COVID ward. Her COVID PCR done twice was negative. The WBC count is normal. Your blood cultures and your sputum cultures are all negative. So what are we dealing with then? You know it's a community acquired pneumonia. Patient is in the ward. You have got a general ward where you got all these patients, and looks like COVID in the middle of a COVID second wave, but your COVID PCR done twice is negative. So what would you do? Sputum analysis negative. So what is this then? Looks like COVID, middle of a COVID second wave, but your test is negative, and she is developing hypoxia. Would you give dexamethasone, wait, investigate further? So that is a question. So the counts are normal. Generally, when you have a pneumonia with a normal count, you're looking at a viral pneumonia. So this lady has a viral pneumonia. The problem is what looks like COVID is not COVID. So when you do a panel like this, so what we picked up was influenza. What she had in the middle of a COVID second wave in Chennai was influenza. She had influenza 2000 H1N1 strain. Okay. You may ask, what does it make in the time of a difference? Influenza, you're not going to give steroids. You're going to give oseltamivir, which is an effective antiviral. COVID with hypoxia, you're going to give steroids. Influenza, we give steroids, it can create a problem. And this lady is in the middle of a COVID ward where all other patients have COVID. She can transmit this influenza to them. She can pick up COVID from them. So it may look like a simple test. Okay, why should we do this test? Anyway, we're going to manage it. This test costs some 10,000 rupees, 15,000 rupees. But you need to look into it. The wealth of information that you're going to get out of this test is going to be very useful. Because this patient is not a stable patient. She's in the sick stage, borderline stage. She may crash down. So this is when a test like this will really make a difference. This is not someone you would do it in a routine outpatient scenario, do a swab. But this is a patient where your information that you get is very, very crucial. And with respect to the utility of this test, prior to 2016, all we had in our hospital was only H1N1 PCR, starting from the year 2009. Prior to that, we do not have any data on influenza at all in India. But influenza has been there for time immemorial. But 2009 was the first major pandemic of influenza. All we had in our hospital was only influenza. But when we started to use this panel in our hospital, that was in the year 2014-15, we introduced it. We picked up, these are all patients not in outpatient scenarios. These are all patients with community-acquired pneumonia, what look like a viral pneumonia landing in your ICU for oxygen requirement hospitalization. You could see that in addition to the H1N1, we have influenza A, H3, we have adenovirus, we have RSV, we have human metapneumovirus. So all these viruses, even though they are supposed to be innocuous for the majority of the population, there is always a significant minority who can develop a pneumonia landing in the ICU. So these are the subset of patients in whom you may not require any antibiotics for treatment. And again, you know that with an antiviral could be given for influenza, whereas other viruses, all you have to do is only supportive care. So unless we do the test, we will not know. Now you have this panel called Pneumonia Plus panel. So what was the initial one is the upper respiratory panel, where you have all those viruses with some mycoplasma, bordetella being picked up into it. Now you have this Pneumonia Plus panel where you have your bacterial pathogens plus the viral pathogens plus the atypical pathogens. This is to be done in the lower respiratory tract sample, the bronchoalveolar lavage or a sputum sample, fairly good sensitivity and specificity. The problem with this test is it even picks up antimicrobial resistance genes, but this test is not an easy test to interpret. If you look into this study, when you do a standard culture, the chance that you do not isolate a bacteria is quite significant. But when what you pick up as a single bacteria is 40%, whereas in 20% you pick up 2 or more bacteria when you do a standard culture. If you do a PCR test like this, you could see in almost 44% of the patients, you picked up 2 or more bacteria. So when you pick up 2 or more bacteria as a clinician, it becomes very difficult to tell which is causing a problem. So whenever you do a PCR, it's very important what kind of sample that you process. So the respiratory tract is not a sterile sampling technique. So you can have colonizers sitting in there. So when you do a PCR, we can pick up dead germs or germs in the small quantities there or just living there, not creating problems. When you do that, when you have reports like this, it becomes a problem. So this is an issue with respect to going for a full PCR-based approach. You may pick up a lot of noise, and that's not going to help you at all in making clinical treatment decisions. But if the same PCR, if done in a CSF, which is a sterile sample, or in your blood, the information that you're going to get out of it is gold. because blood and CSF is sterile. So if you're going to pick up some germ there, it's going to be very useful. But anything in the respiratory tract or your gastrointestinal tract, it's a problem while doing PCRs. So we need to be aware of that. So it's quite clear when the European guidelines recommended saying that should I rely upon these PCRs to diagnose pneumonia, they said very conditional recommendation with low quality of evidence. We don't need to rely upon that for making a diagnosis of pneumonia. So going on to another syndrome, meningoencephalitis. So this is our hospital data with respect to acute meningoencephalitis. All these patients had abnormal CSF picture. These are not clinical diagnosis of acute meningoencephalitis. All of them had abnormal CSF consistent with meningoencephalitis. Look into it, the number one cause for acute meningoencephalitis in our hospital was pneumococcus. Pneumococcus. If we have done this study a decade ago, we would have not had pneumococcus as the number one pathogen there. Why we got pneumococcus as the number one pathogen? Because we do the multiplex PCR panel in the CSF. That has pneumococcus. All of us know that pneumococcus is the number one cause for acute bacterial meningitis. But trying to pick up pneumococcus or prove pneumococcus by a standard CSF bacterial culture, it becomes futile. You are PCR positive, but your culture positivity is only a 10% correlation. So this is where this test becomes very, very useful. You got an acute meningoencephalitis, you do a multiplex PCR panel, and with the help of that, we could make a diagnosis of pneumococcal meningitis as the number one cause for our acute meningoencephalitis patient. There's another study from Kerala, KIMS Trivandrum, in which when they did the panel for around 259 patients with acute meningoencephalitis, you could see the standard culture, the pickup rate was 3%. Whereas the meningoencephalitis panel, the pickup rate was 25%, 24%. So out of 4 patients, 1, the panel picks up. 23% your culture picks up. And they had enterovirus as the number one cause for community-acquired meningoencephalitis. So you could see that if you pick up enterovirus as a cause for meningoencephalitis, you're not going to give acyclovir, it's not required. You're not going to give doxycycline for your rickettsial infection, it's not required. No ceftriaxone, no vancomycin. So it's only enterovirus. All you can do is only supportive management. So when you get that etiologic diagnosis based upon your syndromic diagnosis, it helps you in narrowing down your therapy. Avoid unnecessary antibiotics, avoid antivirals. It will help you in prognostication, telling your patients what would happen. You know that with enterovirus this is going to happen. With herpes, this is going to be the morbidity or mortality. So that is the utility of these tests. Nevertheless, these are all the organisms present in the CSF meningoencephalitis panel. You got a lot of viruses, bacteria, it has listeria, Haemophilus, pneumococcus. It's a fairly good sensitivity, specificity, fairly good positive predictive value, negative predictive value. So where would I use a community-acquired meningitis? At times it can be false positive. The pneumococcus can be false positive. It can be false negative, especially with HSV virus or cryptococcus. It can be false negative. You need to understand that Mycobacterium tuberculosis number 1 is a very important cause for fever-altered sensorium. That is not in the panel. Your India-specific encephalitis viruses like rabies virus, Chandipura virus, your dengue, chikungunya can cause encephalitis. None of them are in the panel. West Nile virus is not in the panel. So this is not an entire answer to your fever-altered sensorium, but it gives you a hand-on regarding what it could be. The latent viruses like human herpes viruses, CMV, most of these herpes group of viruses can go in for reactivation. So interpreting their positivity, the CSF, it becomes a problem in certain situations. Going on to the blood culture identification panel. This is where you guys will if you're going to go to a private practice, or I'm sure probably another 2-3 years, and even in the government setup, you may have access to all these things. But the basic dictum is to send 40 ml of blood for culture. Your blood culture flags. Your blood culture flags gram positive, gram negative. Then you ask your molecular lab personnel to process the flagged blood culture bottle. And if you're going to do this, it will help in identifying the germ, what it is. Your gram positive, you got a huge list of gram positives, your gram negatives. It will help in identifying what is a bacteria. And if there is a resistance mechanism, resistance genes detected, it would say that, okay, ESBL is there. If it is a carbapenem resistance, it would say NDM is there, OXA is there, KP is there, whatever is there. So as Subra was telling you, if it is an OXA positive thing, you can give only ceftazidime avibactam. If it is an NDM positive E. coli Klebsiella, you can try giving ceftazidime avibactam plus aztreonam. So that is where this test will be useful. But the basic starting point will be to do 40 ml of blood culture, and the blood culture has to flag. When it flags, you'll have to ask your microbiology lab to process it, because from the day it flags, generally it takes 48 to 72 hours for you and me to know what drug would work. But by doing this, you can fast track everything. What is 48 hours? You can get in 3 to 4 hours. So that is the biggest difference, impact in terms of time that you can have. This is a patient with obstructive jaundice, and then he underwent a ERCP, found to have some CBD growth, and then post ERCP, this patient went in for some sepsis-like episode, fever with chills, and this patient's blood culture flagged gram negative. So blood culture has flagged gram negative. So if it is the case here, you leave the molecular report here. So what would you guys use? Piperacillin tazobactam. Probably if the patient is sick, you may think of imipenem, meropenem. So this patient was getting ceftazidime sulbactam. And most of us, what we would do is, okay, patient is having fever, dry gut chills, blood pressure borderline. So what we did is the ceftazidime sulbactam was upgraded to meropenem. Then we thought, okay, let us try checking what it is. When we try checking what it is, you know that what we're dealing is with Klebsiella. And you see it is an ESBL gene detected, and then you got an OXA48 detected. So if the OXA48 detection of the Klebsiella, my meropenem is not going to work. So what we chose to do is stop the meropenem, put the patient on ceftazidime avibactam. Suppose if you have gone through the traditional route, I would have just continued with meropenem, and my patient would have been there or probably gone down. Probably I would get an opportunity to change that meropenem to colistin or ceftazidime avibactam, probably 48 hours later. But let me tell you, this change, what we made was done on a Sunday forenoon. Real time, I'm telling you. This blood culture flagged on a Sunday morning. So the change was made on a Sunday forenoon, because this happened to be our hospital doctor. He was our doctor. He got all these problems, and then we thought, okay, I was a consultant on rounds. I thought that let me not miss things. He was looking okay on meropenem, but when I did, I was surprised. It's not like that he received antibiotics in the past. Nothing. All he had was one intervention, the ERCP. Post ERCP, he had this. So it helps. The doctor is alive. He's doing well. This was 5 years ago. Okay. So if not, probably we would have missed him. We do not know. And this is another 62 years female with not much comorbidities who comes what it looks like a community-acquired pyelonephritis. She's come from the community with some fever, flank pain, dysuria. The blood cultures, let me tell you, that is a starting point. If you have to do 40 ml of blood, I know that it's difficult in the setup here. You have to do it, especially in the oncology wards. We have no other choice. Otherwise, you're not starting anywhere actually. So 40 ml of blood sent for culture. All your 4 bottles is flagging gram negative. Again, this patient was on ceftazidime sulbactam. And then the next day, fever was there, very high grade. People gave meropenem. She was still having fever and not getting better. But in general, you understand, you start an antibiotic patient, fever is not going to settle quickly. It takes 40 to 72 hours. But she was looking very toxic. And someone said, why not do the test? Anyway, your blood is flagging gram negative. Try checking what is at gram negative so that you can be rest assured that you are giving the right drug. To our surprise, she had an E. coli, and that E. coli was NDM positive. The E. coli, it was NDM positive, New Delhi metallo-beta-lactamase. So that is the highest degree of carbapenemase that you can have. Oxa is a chota guy, no problem. Sometimes your beta-lactams, meropenem may kind of overcome. Even though ceftazidime avibactam is a drug of choice. NDM, you can never get away with giving meropenem or imipenem. So it was a big surprise. We picked up NDM. And then what I have to do? I put her on colistin. That is what was done for this patient. So that's the kind of impact that you would get when you do a test like this. This is our publication on this rapid blood culture identification, the BCID2 panel, around 200 patients being analyzed. And we found a 99% concordance between our molecular testing and the traditional testing. And the drug susceptibility testing, it is a 96.5% concordance. What the traditional report says and what the molecular support says. The report was available 1.5 days earlier. That is because we use, even in the traditional blood culture algorithm, we have a technique called MALDI off. That is why we get it quite earlier. Probably the routine labs may not have MALDI off. So it is not 1.5 days earlier. It will be 2.5 days if you go by the traditional algorithm. The antimicrobials was tailored in 82.5% of the patients. Polymyxin-based therapy was avoided in 70% of the patients. So that's the kind of impact when you do a test like this on a sick patient, in an ICU patient or immune compromised host. So these were all the pathogens that was picked up, starting from E. coli, Klebsiella, Pseudomonas, Acinetobacter. These were the resistance enzyme picked up. But kindly remember, this test, the blood culture identification panel, is not the absolute test. Whatever is in the panel, it will pick up. There is a huge list of organisms. In our 200 blood culture flags, 40 blood culture flags were not identified by the BCID2 panel because the panel does not have these microorganisms. Starting from your Burkholderia, Salmonella, Elizabeth Kinge, these are all not there in the panel. So it is not in the panel, it will not identified. So there is no point doing only the panel. You will have to do the traditional blood culture. The panel will be a valuable add-on to your traditional algorithm, whatever you have, because there are a list of important gram negatives which is not there in the panel. Your top 4 pathogens, E. coli, Klebsiella, Acinetobacter, Pseudomonas, it is there. But there is a list of gram negatives, it is not there. We need to keep that in mind. This is a post-liver transplant patient who had some incessant diarrhea. So almost 10 to 12 episodes of diarrhea every day. And for 3 weeks, he was on some immunosuppression. You do all the tests, everything is negative. You do a colonoscopy, investigate for CMV, think of tuberculosis, everything is negative. Then you do a gastrointestinal panel. This is a kind of patient that you will have to do a gastrointestinal panel, not your routine outpatient diarrhea kind of thing, because you do not know what are you dealing with. And this is an immune compromised host in which you have to try to identify what is causing the diarrhea. Norovirus is causing the diarrhea. So what is the treatment for norovirus? No treatment, reduce immunosuppression. What is the problem with norovirus? You have one patient with norovirus in your oncology ward, and he's going to use a common loo. He's going to spread the virus to others. It is a big infection control problem. So it will spread. So you may think, what is this going to change? Yes, it's changing. Well, you're not getting good antibiotics. You're not chasing behind CMV. You are reducing immunosuppression. You're placing this patient in isolation. So the test is useful, but provided you know how to use the test, where to use the test. So this is a very useful test. Why is it useful? Because if you do the traditional algorithm to pick up the routine stool cultures, to pick up your whatever diarrhea etiology, it may not pick up more than 5%. Whereas when you do a multiplex PCR like this, it would pick up majority of the times. This test is very useful when it is negative. If it is negative, it almost tells you that you're not having any of the infective causes for diarrhea. It is positive, just like the pneumonia panel, it can pick up a lot of noise. But nevertheless, it is useful in your immune compromised patients. These are all the top pathogens that was picked up in our center. E. coli, norovirus, Campylobacter, Clostridium, Cryptosporidium, Vibrio, a huge list. A huge list. So who should we use this? Not for all your routine patients. Dysentery, yes. Community-acquired diarrhea lasting for more than 7 days. Someone with fever, landing in ICU, multi-organ dysfunction. Immune-compromised host diarrhea, where your routine algorithms are not able to fix it up. Patient has diarrhea. In that situation, it is useful. So to sum it up, all your multiplex PCR panels have their own list of advantages and disadvantages. Advantage, definitely enhance etiologic diagnosis. It tells you what are you dealing with. Much better than your traditional work algorithms. It's very valuable in guys who are critically ill, who are immune compromised, transplant hosts. It is very easy to do it. All you have to have is a molecular lab, because it can be processed for that one single patient. You don't need to have a bunch. You don't need to do it for 10 people, all those things. You have a blood culture flag, you want to know what it is, that particular sample alone can be handled. All you have to have is a technician who will place it in that machine cartridge, and the machine will read out the report. That's it. It's not high-fund thing. It's all automated, actually. It aids in hospital infection control. appropriate antibiotic use. But what is ailing it is it's the cost. The basic cost of that test is around 8,000 to 9,000. So whatever is commercially available is around ranging from 11,000 to 18,000. 11,000 to 18,000. So probably in a government setup, if they're going to bring it up, probably it will be at 7,000 to 8,000. The institution has to bear. That becomes a problem. So JIPMER is one center where they have introduced it and they're using it actually. What are the disadvantages for all these tests? There could be a lot of music as the information that you get from your blood culture or your CSF, but the respiratory cultures or your gastrointestinal panel will pick up a lot of noise. You need a smart clinician there. The cost, for me, in the long run, the cost could be its advantage also. Why? Because you minimize unnecessary further tests, you give the proper treatment, you kind of cut off drugs, you cut off antivirals. So the direct cost on the test may be actually offset by the other added cost that you do for something else actually. Availability is a problem. It's not available. Even if it is available, whether it is accessible, all those things. The problem here is the drug susceptibilities are not available. All these tests will tell you what drug would not work. It picks up the resistant genes, that's it. It never tells you what would work. So that you will have to definitely do the traditional culture. It will not tell you what will work. It will tell you what will not work. So that is a different proposition actually. So you again know when you have the report, a clinician is required there. I think we have to Indianize it also. So whatever is prevalent here, these are all Western tests. These are not Indian Indian need driven tests. So we may have to Indianize it. The future will be like this. Right now, what we are using is multiplex PCR. The future will be next generation sequencing. This is a guy with a boy with a severe community immunodeficiency, undergoes bone marrow transplant, and then has an immune reconstitution syndrome during the bone marrow transplant. This is a US boy who presents with fever altered sensorium, thought to have a meningoencephalitis. They do all the tests in the world, not able to pick up what it is. And then they do the next generation sequencing, they pick up leptospirosis. This is in the US. They picked up leptospirosis. Then there was an epidemiological exposure. This boy had some swimming pool exposure or some pool exposure actually. So this was 10 years ago. This was 10 years ago published. But right now, are we having this technique available for our widespread use? No, it is still in development, next generation sequencing. So what we have in our hospital is a one form of next generation sequencing, which is the 16S RNA PCR. That is what we have, ribosomal PCR. This is a patient with a purulent pericarditis with pus. So when we tried doing the PCR testing, we picked up pneumococcus. This is a post-renal transplant patient with a surgical site collection. Post-renal transplant patient at the surgical site, there is an abscess, perirenal abscess, surgical site. When we tried doing it, we picked up Mycobacterium abscessus, which is a non-tuberculous mycobacteria. So that is how these tests will be adding value. But the problem with these tests is they may not be the answer to the entire problem. You should know how to utilize this test, when to utilize the test. These are not as simple as your single PCRs like H1N PCR, CBNAT, or COVID. Anything that is multiplexed, it needs a clinician interpretation. Anything that is next generation sequencing or whole genome sequencing, the clinician in you has to be active. Otherwise, this is just a piece of paper for you to interpret. You have to choose your patients and then interpret the results in conjunction with your clinical all other apps. That this paper alone is not going to give you the answer. But I have just selected out patients where it was useful. There is a list of patients where it was giving us junk also. Okay. So before we order for all these molecular tests, you always check whether these are standard tests, whether it is approved by some external organization like WHO or Indian government, ICMR, or something. Is there a recommendation for that? Or they just have developed a test in-house. You have to look into that. That PCR word is not the mantra. Okay. That is very, very important. So external quality control, all those things are very, very important. Many times people are searching for quick answers. And all they want is something to say, okay, this is there, that is there. but how valid is the information is the question. This is just like your whatever molecular phenotypes that you would be doing for your oncology patients. You need to send it to a good lab. I cannot rely on some junk lab for me to, just because it has said this technique. Similar is all these infective etiological PCR workups. You need a good lab. Without a good lab, that paper is not useful. Time is tissue in management of patients with sepsis. Rapid diagnostic tests are very valuable in management of critically ill patients, immune compromised hosts. But I strongly believe your traditional testing will remain the backbone. Whatever test that you're going to add on will add value to your existing workflow. It's not going to change the traditional working algorithm. So as clinicians, we are in evolution. As we proceed further, we may have to integrate all these new information that is being poured into us with the traditional algorithm. The traditional algorithm will stay, but this we should know how to interpret. That is where it stands. This is not the best. This is definitely not the best. This can try to help you. That's it. But this will stay. This will grow. As clinicians, we should know how to interpret, how to utilize these rapid advanced tests kind of thing. That's it. Thank you. Look, Malditoff is a traditional bacteriology-based test, okay, where you, by a different technique, you try to identify what is a bacteria. It is not a proper molecular pathology-based testing at all. You don't need a molecular lab at all. It is nothing but the fast tracking of the routine bacterial identification without going into a proper molecular diagnostic approach. Based upon the degree of ionization of the bacteria, it would try in identifying what is a bacteria is. That's it. Right now, Malditoff can identify what is a bacteria. For that also, the blood culture has to flag. It flags by the end of 4 to 6 hours, you will know what is a bacteria, but it will not pick up any resistance genes. Your blood culture identification panel will pick up your resistance genes also. In the future, you will have Malditoff technology giving us answer on the resistance gene also. If that is the case, then you may not need the multiplex PCRs. But right now, whatever we have Malditoff, it will help in identifying only the bacteria. That's it. It will not help in telling you whether the bacteria is harboring any resistance genes or not. Yeah, we have everything.
My question is regarding this panel. Where is it available in Chennai? Supposing I want to send something for my patient who's here. One, where can I send it? And two, where can you suggest help with patient selection? Because febrile neutropenia patient has come in shock or something. There is no focus of infection. We have started on empiric antibiotic therapy, and like you said, it can be any resistance. We don't know. So, at what point of time would you suggest that we set this panel?
It all depends upon your whatever it is. The problem with febrile neutropenia is you don't get a syndromic diagnosis in the majority. So in the non-neutropenic patient, you always have a syndromic diagnosis. In febrile neutropenia, most of the times it is an undifferentiated fever syndrome. This panel will be helpful only when your blood culture flags. Right now, we don't have any test which is foolproof or which is 100%, which will be very useful for you to tell you. You do a blood, you do the multiplex PCR in the blood directly and telling you the answer. Some labs claim that they can do it, but it is not worthwhile pursuing that. So for you to pursue any multiplex PCRs, you need to have a blood culture flag. Only when your blood culture flags, if you wait, if your blood culture flags on a Monday, probably it will take Wednesday evening for you to know the right antibiotic. But if you do the multiplex PCR, probably on a Monday evening itself, you will get it. Almost all the private labs now do it. Our hospital, Apollo Hospitals, does it. The private labs like VRR Labs, Anderson, they all do it. VRR, in fact, has a tie-up with Child's Trust Hospital, where they do it as a subsidized rate. Normal labs, most of them charge around 15,000. We are at the tie-up with Child's Trust Hospital, Kanji Kamakodi. We do it around 11,000 rupees. That is where it can be done. But only when the blood culture flags, it will be useful. We cannot do anything directly on the blood.